speak about distal occlusions, trial and devices. And first we need to know is how good are we identifying the distal occlusion. There's a mistake here. Where most of the times the diagnosis is made in these circumstances, but more and more we take this acute, hyperacute diagnosis using our mobile phones, our cell phones, and we are assessing CTA on our mobile devices. And therefore, the decisions to treat with endovascular treatment are made within minutes. So now, we should keep in mind that we might think that we are good detecting these occlusions, but there is growing evidence saying that we might be missing some of these distal occlusions. Sometimes we might think that there is two branches here, a bifurcation, but in fact, the patient may have a trifurcation and we are missing one of these branches. And even we might be missing few times more proximal occlusions like M1 occlusions. So what is being proposed more and more is to guide the decision with enhanced imaging techniques such as CT perfusion. You can see that sometimes you may think that these occlusions are very obvious, but as I said, in the acute phase, you might be missing them. So this study showed us, they took a mixed data set of 70 occlusion, distal and proximal occlusions, and you can see how if you give the radiologist a CTP at the same time, it increases the sensitivity by 20 points. And not only this, you also speed up the process of identification. It takes much less time to identify the occlusion. So it's probably good practice to start thinking that CT perfusion might help us in the acute phase, even in the early time window, not to assess the infarct core, but to help identify distal occlusions. These are real cases from our institution in which initially we missed the occlusion on CTA, and because we perform a CTP in these patients, we could identify the occlusion. And sometimes these occlusions is not so distal. You see here it's 73 milliliters of brain that is hypoperfused. Here's another case that seemed obvious to us that there is no occlusion on CTA, and we missed it. And in fact, on the CTP, we could see that there was a distal occlusion. So because of this, we decided to do a study in our hospital during 6 months. We decided that all comers, all stroke code comers would have basic imaging, and if there was no bleed, they would also get a CT perfusion independently of the time from symptom onset. And this is what we observed. We observed that you have all these diagnoses, but about 14% of the comers, of code stroke comers, they had a distal occlusion. And sometimes these distal occlusions, they are not so small. For M2s, you can see that the median time Tmax greater than 6 seconds was 50 cc's, quite large. So here we set what we call the ground truth based on full examination of all imaging, included CT perfusion, and then we asked in parallel physicians to find the occlusion only with CT and CTA. And you can see that they missed around 10% of the occlusions would have been missed if CT perfusion was not available. Now for the indication of EVT for this distal occlusion, how clear it is. So there is not much evidence But from this article, from European associations and guidelines, experts gave their opinion that when it comes to M2 occlusion, it is reasonable to perform endovascular treatment. However, there's not full evidence. And this other study did a survey among many physicians around the world, and they saw participants different scenarios with patients with what we call mid-sized vascular occlusions, different scenarios, and that was the answer. Roughly, about a little bit more than half of the participants, they thought that these patients with mid-sized occlusion, distal occlusions, they were candidates for endovascular treatment. However, 30 to 40% of the cases, physicians thought that there was no indication for endovascular treatment. And here are some of the reasons that led to not indicate endovascular treatment. The benefits were believed to be too small. There is not enough evidence. There are not enough resources in some of the countries that participated. The occlusion was too distal, or the physician thought TPA will be enough, and therefore they decided to withhold endovascular treatment. That's another very recent study from this month. In this study, they are addressing kind of different scenario. Now we're not talking about distal occlusions from the beginning, but we talk about these patients that arrive with a proximal occlusion, and during the procedure, there is a substantial recanalization, but not complete recanalization. And now there is a what they call residual distal occlusion after initial thrombectomy. What should we do in this case? After we did a thrombectomy, should we chase these distal clots or not? So the results are very interesting. You see that from 700 patients, they excluded those with initial distal occlusion, and they kept only those with an initial proximal occlusion that after treatment, 26% of them, they had a distal residual occlusion after initial endovascular treatment. And they compared those in which the physician decided to treat these distal occlusions and those in which the physician decides not to do anything else. And here are the results. Apparently, if you decide to go after these residual occlusions, the outcome of the patient is going to be better. You are improving the outcome. So you should not leave these distal occlusions as reasonable it can be. I would add, you shouldn't go if you think it's not safe to go there. But as a general conclusion, you should try to chase this distal emboli and try to recanalize and to get a full recanalization. So here's the scenario. We know that the benefit of endovascular treatment is very clear for proximal occlusion, and it fades for more distal occlusions. And the same happened with the NIH for very severe strokes. It is clearly benefiting endovascular treatment. And we obviously know that very distal occlusion with very low NIH are not going to benefit. So where is exactly the limit? Where should we put the limit? Anyway, there are different ways to treat these occlusions, technical ways, I mean. You can do aspiration with no matter size of the catheter. Even this work describes aspiration with an O27 microcatheter, and you can still take out these little clots. So this is a technique. I believe the combination of stent retriever is also safe. There are multiple stent retrievers with a lower profile that are specifically designed for this kind of distal occlusion. And I think it's a wise to combine always your stent retriever with a distal access catheter and local aspiration first, because you protect distal emboli to go to other branches, of course. This is the first reason. But the second reason is the one that I'm showing in this video. When you perform a thrombectomy with a stent retriever in distal branches, this is what might happen. You are, your forces, the vectors of the forces that you're using, here's your blue microcatheter, you pull, and you're pulling the wrong way. The force is applied wrongly, and you might shear and dissect here the vessel. This is what you don't want to happen. So how can you avoid this? As I said, by giving support with a distal access catheter, instead of pulling like this, and in this condition, the first thing you need to do is to approach with your DAC, you give support, and now when you pull your microcatheter and your stent retriever, the vector of the forces is different, is going this way. You are not going to cause the harm that we've seen before. And therefore now your procedure is going to be more safe and more effective, as you can see in this example. So distal access catheters were created and invented to give support in these cases, not only to aspirate distal occlusions. Again, another case in which when there's no DAC, you are pulling and you're jeopardizing the geometry. If there is a DAC, when you pull, the branch doesn't move. What should we do in cases like this? Again, another option, when you find yourself after an initial thrombectomy with this distal thrombi, should we use intraarterial lytics? Again, this is another survey in which there were multiple opinions from multiple operators. Many of them thought it's interesting to give intraarterial TPA, others didn't, or even do more mechanical thrombectomy in these cases. From this registry, from the NASA registry, you can see that the patients that in which intraarterial rescue TPA was given, they achieved even higher rates of complete recanalization, and this is encouraging. So it might be encouraging, but we don't know if it's safe enough. And this is why there is at least a couple of studies, but here in the area of Barcelona, we participate in the CHOICE study, which is investigating the safety and efficacy of administering intraarterial TPA after the mechanical thrombectomy if there is some residual clots in distal branches. We're going to soon have the answer of the CHOICE study. Now, what about the posterior circulation? This is also quite recent study in which they investigated thrombectomy in distal posterior circulation occlusion P2 and P3. You see that the rate of complication was low. Dissections, perforation, embolizations, low, and the rate of complete recanalization, either at first pass or with more than one pass, was quite high. Now, they did this study in which they compared patients with these occlusions that received thrombectomy with matched controls that did not receive thrombectomy, that only received best medical treatment. And here's the comparison in outcomes. The patients that received thrombectomy, even if the occlusion was distal, they had better outcomes, slightly better outcomes. And especially, the situation favored the use of thrombectomy if the patient had a quite high NIH, greater than 10, or if the patient had a contraindication for IV TPA. So if you are not going to benefit from IV TPA, it's more beneficial for you to get a thrombectomy also in this posterior distal occlusion. The last study that I want to mention is this one. This is a very large study, more than 4,000 patients, in which at the end they defined distal occlusion as, like you see, very distal, M3 occlusion, ACA, and PCA. And they did some comparison between proximal and distal occlusions. The rate of treatment and the distribution of the treatment was quite similar. You see that the time to reperfusion was exactly the same for distal occlusion than for proximal, so it doesn't take longer to recanalize a distal occlusion. And here you can see the rate of complete recanalization might be a little lower, 78% for distal occlusion, and especially you see it was a little lower for A1 and A2 occlusions. However, the complications again were similar, mortality, hemorrhagic complications. So if you can perform safely these thrombectomies in very distal segments, and here you can see the predictors of good outcome. Of course, age and NIH as always, but also successful reperfusion. In distal occlusions, if you reperfuse, you're going to have also better outcomes. Here you can see the higher is your Tiki score, the higher is your chance to have a good outcome. So I cannot tell you exactly where should be the limit, but you should, as much as possible, I think, try to chase and to treat this distal occlusion. Still, we don't know where is the limit. And I will stop here, and I will get back to you with the presentation. I will stop sharing my screen.
Marc, thank you so much. Excellent, as always.